Hi, my name is Jon Howard, and in this video we're going to talk about Introduction to Simulation and how we do it here at the University of Virginia. So our objectives in this video: to discuss what simulation is, to describe some of the benefits of simulation, and to discuss the simulation process. So what is simulation? A simulation is anything where you're practicing with a patient who's not actually a patient. For us, most times that's going to involve a mannequin. Every once in a while, it can involve somebody called a standardized patient who's a real person, but not a patient. Obviously, there's some rules about what you can do with that person. But simulation is we're practicing with somebody or something that's standing in for the patient. That allows us to give the participants exactly the patient we want them to see. There's not close enough. It's not hoping that I get a chance to see this patient during my orientation. We can give you exactly the patient that you want your participants to see. There's a lot of discussion in the simulation world about high fidelity versus high realism. At UVA, in the Health Center, at Life Support Learning Center at least, we aim more for high fidelity rather than high realism. We are not going to get a perfect room where someone looking at it would say, that is a hospital room and I understand exactly what everything is in there. We go for high fidelity. We want people who are participating in the simulation to believe this is a real patient, at least sort of temporarily for a while, but acting and responding and treating that patient as if they were real. And there are some ways to do that, but that's what we're looking for. We want them to have the same response to our mannequin or to our standardized patient as they would to an actual patient. What are some of the benefits of doing this? Lots of different levels for this. One, we're just going to get you some additional practice. You have low frequency, high acuity patients who come to you. Let's practice with some of them before you get the actual real patients. We can do that practice in a way that's safe for both patients and participants because there aren't any patients around as part of the simulation, but it's also safe for the participants as well. The mannequin is plastic. If something doesn't go perfectly, that's okay. The mannequin is plastic. It's better to make a mistake with a plastic mannequin than it is to make a mistake with a real patient. And by practicing on the mannequins, is less likely that you will make any of those mistakes. It is more likely that your care will be better for actual patients. We also have the ability to discuss why. So when we do a simulation, we have a debriefing afterwards. And now we can discuss all of those things about why did this happen? How did this go? Why did it go that way? Your patient had a blood pressure of 140/60. Why? Why was there such a big gap between the systolic and the diastolic? What was going on with your patient? And that allows those providers to think about what was going on, to process that information, and then be able to use that information and do that same kind of processing with actual patients later on. Putting all those previous things together, this increases provider confidence. I've seen this patient before. I know what's going on with this patient. I know why we should be doing whatever it is we should be doing. And there's also another level of simulation as well. Most simulations that we've done in the past, and most times when people think of simulation, they think of a simulation where I'm treating a patient and I want to know how to clinically treat that patient. There are other simulations as well. You can do simulations to see how systems work, to work on workflows, processes, patient flows through an area, new standard operating procedures. Will they work? How do they work? Do we need to tweak anything to make them work better? There are lots of different levels of simulation that are available and that are helpful. Preparation for simulation. We're going to start walking through the steps of how we're going to do this. Before we run a simulation, we're going to prepare for it. The biggest thing with this is, what are the educational goals? Why are we doing this? If we're doing a simulation just because it's really cool, that's great. It's not really great, actually, right? Why are we doing this? What do we want the participants to get out of this? What do we want the health system to get out of this if you're doing one of those system simulations? What's the point for this? And that drives everything else. The way the scenario is built, the way we are hoping that people will go through the simulation, all of that is driven by the educational goals. Why we're doing this. And then you build the simulation around that. Once you've got your simulation, once you've got your scenario, this is the way we think it's going to go. You can prepare for it. I need a mannequin. I need supplies. I need props. I need people. Occasionally people are props. They are people we put into the simulation who know what's going on, but they have a specific role to play to make something happen. Get all that preparation ready, and now you're ready to run the simulation. Again, we try to maximize fidelity with this. Our mannequins can do certain things. They can't do everything. We're not going to be absolutely perfectly high fidelity, get everything absolutely correct. We need to get close enough. So if I've got participants who are working for a patient who's in hypovolemic shock and is crashing, and I tell them, here's your blood, and they look at it and it's clearly red colored water, they get it. It's blood. I need to check my blood. I know it's not really blood, the same way I know this is not really a patient's mannequin, but I'm in it close enough that I have that fidelity. So we want the mannequin to have as much fidelity as we can. We want the situation, the environment to have as much fidelity as we can. Sometimes we're running these in day rooms or simulation rooms, and sometimes we're running them in actual patient rooms. Again, you can work with the environment to increase the fidelity for it. Before we run the simulation, we're going to set expectations. Here's why we're here. Here's what's going on. Here are the rules of the game. You can do this. You can give your patient medications through the IV that's in their arm. You cannot poke the mannequin with a new sharp to make a new IV. We have a different way we're going to do that. What can I do and what can't I do? If I don't know the rules of the game, then I'm just going to get trapped somehow. Let them know what the rules are. Why are we doing this? What are we expecting from them? Big thing with that is that we're not going to be grading them. This is not for a grade. It's not a test. It's not anything else. You can use simulations for tests. The ones we tend to do here at UVA and the health system are not. They're educational experiences so that you can learn from them. The simulationist during the simulation is the stage crew, not the director. You should not be the star of anything. Ideally, the simulationist disappears into the woodwork, into the walls. The participants don't even notice that you're there. All you're doing is making things happen so that they have the experience you want them to have. We are looking for participant suspension of disbelief. I know this isn't a real patient. This is a mannequin. I'm going to treat this as if it were a real patient. And there's a little bit of spotlight syndrome. When you're participating in a simulation, other people are watching you. You know that other people are watching you doing this. And sometimes that makes people nervous. They are concerned that maybe they will not do something right, and then people will think less of them. They are a highly experienced nurse or physician or respiratory therapist. I know I'm good. And the simulation has a chance of showing them they're not as good as they thought. This is a concern, and it is a legitimate concern. Again, go back to your expectation settings. We're here just to give you an experience so that you can learn from it, so that you can be better with your patients in the future. We're not going to take a metaphorical bat and beat you over the head with it. We're just here to help you be better with your real patients when you're done with this simulation. After the simulation runs, we're going to get into the part that's actually more important, which seems a little strange. The simulation isn't the most important part of the simulation. No, it's the debriefing afterwards. That's the place where you have a chance to talk. What happened? What went well? What would you like to do differently next time? And we phrase that second one very deliberately that way. It's not what went wrong. It's what would you like to do differently next time? There's lots of different levels of things that could fit into that. And some people really do want to critique themselves. I did this, I did this, I did this. Sometimes you have to sort of drag them back to the what went well part. And then, so that's the plus delta. What went well is the plus. What would you like to do differently next time is the delta. And then we also add in extensions. What if? What if this patient's blood pressure wasn't quite as bad as it was? What if this patient's heart rate was higher? What if the patient was talking to you? What if the patient suddenly had something else happen? Right? We're not going to give them something that's completely strange, but something reasonable that might have happened to this patient. Sometimes those questions allow people to sort of solidify where this patient was on sort of the whole sick versus not sick spectrum. Some of the what-if questions I like asking the most are not the ones where the patient's obviously well or obviously sick, but the ones that hit split right down the middle. I'm not sure if they're sick or not, because that's the one you have to think about the most. And we also do QA/QI. What we do here at UVA mostly is by sending out a survey afterwards, after each of our simulations. Our surveys consist of open-ended questions. We're less concerned about knowing the Likert scale responses from our participants, and more interested in what did you think? What went well? What could we do differently next time? Is this worth your time? It's a little bit of a yes/no question, but questions asking them to expand on what they saw and why they liked or did not like the simulation. This is our version of feedback. It's our version of a debrief. We talk about how our simulation went in our hot wash, which is a simulationist only, right afterwards. And then we look through the survey responses to see what the participants thought. In summary, simulations have a structure to them. Why am I doing this? What's the educational goals? How am I going to prepare for it? How am I going to run it? How am I going to talk about it afterwards in the debrief? And how am I going to improve my simulations for the future?